In the meantime, while I'm waiting that my presentation will start, I want to thank you for the opportunity and the invite. Right, okay, just had to press the button. So, we heard a lot about fertility preservation already, and I think that fertility and sexuality, they are linked naturally, but I think it's important to just not stop the discussion there, but also look ahead. And so the title of my talk would be the role of the healthcare providers in supporting childhood cancer patients and long-term survivors with body image and psychosexual well-being. So I would like to start discussing why ticking the box of preserving fertility will not ensure a psychosexual well-being ever after. And then I would like to take you on a metaphoric journey and to show you why body image and psychosexual well-being is not just luxury, but essential for quality of life in our survivors. And then finally come to the role of the healthcare providers. What are their attitudes, barriers towards sexual health, and how we could potentially improve the situation. So I know this slide you know all better than me, so I think we all can be very proud that we can say that we have improved the survival rates to 80% of our survivors, which also leads to very impressive numbers that 1 out of 530 young adults in their reproductive age between 20 and 39 is a survivor of childhood cancer. And as we heard already, that it's also a side effect of this new treatment strategies is the gonadotoxicity. So there is an impact on fertility. And what we know from the adult setting is that fertility is extremely important of the quality of life in cancer survivors. And we now also have the same or similar data from young adults. So 80% do want to have their own biological children. And there's a decrease in quality of life in case of fertility issues. And I think this is a very important and impressive statement that infertility is perceived as fatal as the cancer diagnosis itself. So when we now have a look on the referral of fertility preservation, I just rely on your presentation, what we had before. So I think, especially in the adult setting, it did become a standard of care. But in the pediatric setting, it still is, I think, more and more difficult because there was not a lot that we could offer, especially in the pre-pubertal, which is now improving thanks to progress in research. So now I think the awareness of fertility preservation is becoming more and more prominent, but we still have this as a Dutch study, and I apologize, this is from 2013, but it's still well done. So it's over 1,000 cancer patients has been analyzed, and there were only 4.5% has been addressed to discuss fertility at the age group below 20. And I hope now we are getting better, but I think there's still a lot to do there. But this is one side of the story. But what's then? So we are in a survival conference. So I want to point out that I think it is what we want is we want to improve the quality of life. We want to met the unmet needs that they will have the chance to form a family in the future. But do they really do that? So I think the utilization rate of frozen gametes, we do not know a lot in the pediatric setting because they're still too young to get back their frozen gametes. But from the adults, we know that only 10% will come back to use their frozen sperm, and even lower numbers for oocytes. So of course, this is difficult to assess because people are lost from follow-up and they are moving. But what could be the potential cause? Of course, in the best case scenario, they just are conceived naturally. In the worst case, they would die, or there's a recurrence of the disease, or they just decide against having a family, or there's a lack of a partner. Because my point is, before you can even think of having a family, you first have to have a partner, in most of the cases at least. And before you're allowed to have a partner and engage in a relationship, you first of all need to feel good again in your body. So that's why the body image comes into the discussion. So what we do know from especially AOA survivors is that they experience difficulties in building romantic relationships, are more often single, socially isolated, and do suffer from sexual dysfunction compared to peers. So when we now start with the body image, I think it's always difficult to really describe what that is. So for me, it's body and mind is kind of like yin and yang. It's inseparable. So when you're not feeling good in your body, you will also not feel good in your mind, and the other way around. But what we usually see is from this drawing from Magritte is the surface. When we look in the mirror, it's just the facade or the surface, and the inside is more transparent. So body image is more than just what we see in the mirror. What we ask in our therapeutic setting is, do you occupy your body? And by thinking of what else do we occupy, there came the houses in my mind. So when we now think that we are all born like houses, so once it's the outside, so the facade. So the facade is given by nature, whether we like it or not. So it can be a more modern version or a more simplistic version. It's like a little tiny hut with a huge roof and tiny little windows. Or again, this more simplistic version, or if you're lucky, you were born as a castle. But tastes are different. So, and even if you could be lucky to be born as a castle, but we are all exposed to weather and atmospheric conditions, like we are getting older, and there are damages, permanent changes. So to a certain degree, we can try to restore it and fix damages, but to a very large extent, we just have to live with it. You cannot make out of a tiny little hut a castle. So, but we're not alone in this world. So we have the neighbors who are judging us and judging our facade. So, of course, everybody would love to have this cheering crowd in front of us and say, wow, how beautiful is that? And everybody is afraid to have these guys standing in front of them. So, but what they all have in common is that by just looking at the facade, that said how beautiful it must be to live in this house, or how miserable it must be. And this is another story, because the inside is different. So it might be that you look through the window of this beautiful castle and you find it's empty and cold. So in contrast to the facade, I think the inside is different. So because we do not come fully furnished. Some furniture is already there, but the decoration process is ongoing and independent. So everybody can make a castle in the inside. And when we now think of these neighbors standing in front of the houses, and it comes to stormy weather and bad weather conditions, would they just run into the first house that they have, or would they perhaps look through the window, and when they see this cozy little chimney, where would they want to get sheltered? Probably in front of this little chimney, even if the outside is not that promising. So what I'm about to say is, I think the main task is to make us feel at home again. But now, how can I bring sexuality into the picture? So then I was thinking about the Garden Eden. Because, I mean, the Garden Eden is as promising as sexuality is. There is milk and honey running down the rivers, but this is what we usually find. It's a construction site. And especially in puberty, you do not really know what becomes of these little buds that you start to discover. And what you do is perhaps you will look over the fence to your neighbors and say, okay, have you had that as well? And, you know, oh yeah, I saw it. And then you said, no worries. I mean, this will come. And then in the end, you will also have a great cherry flower tree. But what if you will just discover this creepy flower? Would you also go to your neighbors and show it around, knowing that he has a nice cherry flower buds? Probably not. Which would be a pity, because then nobody will tell you that this is a desert rose. You just have to water it. And then it will become a different, but perhaps even more extraordinary flower than all the others have. So again, what I'm about to say is, I think the size and plants in our garden might be given by nature, but it is in our hands to make us feel at home in it. And if you're not a garden type, you do not have a green thumb, then you can leave it. But it's just you have the opportunity to make the best out of it. So if we now think, okay, we have now this beautiful house, beautiful park, we are nice when we are settled down, then cancer comes. And I think cancer is like a tsunami wave. And as I said in the beginning, I think we can be happy to say that most of the time we do not lose the entire house anymore, but it does not look the same. It is a construction site. And I think all the things that you used to like in the end of your body and on your garden, whatever, suddenly it's gone. So you do not know how others will react, how you should feel comfortable again in your own house. So of course, you first of all have to struggle to rebuild it. So I think that's why for me it's absolutely logical that the impaired body image due to physical side effects of cancer treatment is one of the main concerns in our patients. And of course it does influence self-esteem and intimate relationships, because would you really open the doors? I mean, you first of all need to feel at home again, and then you can dare to open up, let body in. and then perhaps one day think about the gardening. So that's why I think it is normal that our survivors do reach sexual milestones later in life. And there's a higher risk of sexual dysfunction. And it's over 50%. It's even 2 years after diagnosis an ongoing problem. Females are twice as likely as boys to have problems. And the problems, which is very interesting, is not related to poor general health, specific type of cancer or its treatment. And of course, they have a fear of being a less valuable dating partner, and they struggle in building and engaging in close and romantic relationships. So what are the risk factors? So which means who should we especially be careful about? I think this is, again, kind of logical, those with a low self-esteem and negative body image, especially neurotoxic and gonadotoxic treatments, especially when it comes to early ovarian insufficiency and the peripubertal age. And why is that? Because the pubertal development might be interrupted during the treatment, but the sexual feelings and desires stay the same. But there's a lack of opportunity to discuss. You cannot share these experiences. There's an isolation of peers because they are very often in hospital. They are perceived rather than children than as sexual beings. And there's a lack of intimacy because we have to go into the room each and now and then how can you ever find the time to discover your sexuality when you risk that somebody will just punch in? So I think it is a very strong statement now, and we have more and more data on that our survivors report that sexual health is one of the most important aspects of quality of life. And they would desire a health counseling. But in contrast to the fertility counseling, in up to 95%, they have never been addressed or had the opportunity to talk about sexual health. So what are the potential barriers? Why don't we talk about it? So on the professional side, there's the own embarrassment and fear to might invade a privacy, and the belief that sexuality is defined solely as sexual function. That's why boys are more often asked than girls. It's easier to access, just ask about erection. And the belief that sexuality is not part of the presenting problem because it's still cancer. And the clinicians' own lack of training in knowing how can I talk about it. And on the survivor side, of course, it's for us as well. I think it's not a topic easy to talk about. It's the discomfort and embarrassment. And of course, the time constraint during a medical visit, not being asked, and the hope and helplessness towards possible existing solutions for their problems. Going further, what they cite is a discomfort. I don't want to make my provider uncomfortable, which I think is interesting. And the initiating, he didn't bring it up or she didn't bring it up. And the validation, I'm worried that there are so many other things that seem more important. It's going to seem like I'm not grateful to be alive. Again, this luxury problem. So what we did, we wanted to know a little bit more about the barriers and the attitudes of oncology, pediatric oncology health professionals. So during a talk on the Oncofertility Summit in Melbourne, where I did stay for a while, we did ask the participants, and there were 80 people joining our survey, and half of them were clinicians, the other half were nurses and psychologists. So first, how do you perceive the importance of the body image? And it is in 98% they would consider it to be important to very important. And how would you rate your degree of knowledge? Well, it was rather lower, so it is moderate to non-existing at 72%. And the same for the confidence in talking about that. Again, it was 70% who didn't feel that comfortable to talk about it. And so often are you involved? So at 55%, it was rarely discussed. And who did bring up the topic? So in 22%, again, it was not discussed at all. And only 9%, the patient did bring it up. So what are the main obstacles? So only 5% there was no obstacle at all. And the major obstacle was that there's a lack of further information, supportive tools. Because most of the time they wanted, they are really motivated, but what if you get stuck in the discussion? What if there's a creepy question? And then of course it would be easier if you have something to give or to rely on, said, hey, okay, in this case, thanks for sharing. You should perhaps see somebody else who knows more about it. So, and in 98%, they would use this information. Anyway, so what are the next steps? So what do the survivors tell us? They want a direct communication from the clinician. They want the clinician to initiate the conversation, and they want an ongoing conversation. It should not be once in a while. It should be really repetitively, because of course they're getting older, and then they sometimes face issues only along the way. And they want time alone with the clinician and normalize the conversation and to individualize. So of course it's not easy. It's easy to say, but it's not easy to find a strategy, because it's not a one-fits-all strategy, and everybody of us is different, has different needs and different expectations. So, but I think what is a very known model, it's the implicit model, which comes from Annan, was developed for sexual dysfunction and sexual therapy, but I think it is very useful also for this setting. So when you start a discussion, first get the permission. You can say, there are many survivors who encounter problems. What about you? To just invite and open the discussion. And then the big part is giving information, because there's so many myths around, and there's a need to clarify and to demystify. And only then it comes to specific suggestions, so personal suggestions like hormonal therapy or behavioral intervention. And only then it's the intense therapy necessary, which would be sexual therapy or psychotherapy. And what Annan already did discover, that in 90% he could help the patients with the 3 first steps. So what I'm about to say is not everybody needs to be a sexologist. It is about to open and invite the discussion, give information, and this is most of the time already what is enough. So what could we do? I think it's to demystify the Pandora box, enable everyone to talk about sexual issues with respect to their personal limits and comfort zone, for sure, offering the information in a routine way so that the survivor does not feel he's the weirdo who is the only one who has been asked, but in a natural and routine way, and develop information tools for patients and healthcare professionals. And I think it's important to define clinical pathways and referral strategies so that you really dare to open the discussion. So from what could there be as well? So this is from the US, just some examples. I know it's not everything which is out there, but it's just that would be an idea to just ask in a routine way before the consultation if they might have a problem, so that you know, and that also the patient would know, okay, they are open and I can also bring up the topic, but this is only if you're sexual active, but there's others. So also for those who are not sexual active, this is regardless of age, partner status and sexual orientation, but only for females. And then after you just address the topic and ask for it, what do we have for sexual recovery in survivors? There's still a lack of evidence-based sexual health intervention, even if they're coming up. They are more and more available. And there's just one, I think it's very good, from Sweden. But what they do is that they screen if there is a fertility or sexuality-related distress. And if they do have one, then there is a module, like an online model tool, which seems to work very well. Coming to our project, what we want is to go beyond that. We want to prevent they even will develop the distress. So what we were starting in 2017 is a consultation, but what we also see is that not everybody has the time to come over and see us in clinic. So that's why what we did is that we started an organization with interdisciplinary members, all dealing with oncology patients, like psychologists, survivor nurses, and pediatric oncologists. And we did develop a platform, so it's a website where we give information. We will now, it's just started, so we will also provide videos and podcast series. We do workshops for survivors, which is with circus artists. It's really that they can trust again in their body, and communication workshops, but practical, not online, practical ones where you can really train how I feel asking questions, what are the most creepy situations, etc. And we do that all as a co-design. So we involve also survivors, so they will give us their feedback, what they want that we talk about, etc. So I have some flyers with me. And anyway, you can always ask me if you're interested. Anyway, so finally, our take-home messages. I think fertility preservation discussions are of great importance in pediatric oncology patients, but body image and psychosexual well-being should equally be integrated, especially in survivorship care. The main aim is to feel at home in our body in order to be able to open our doors for others and maybe to our garden. So I see ourselves as construction workers, and I think it would be great if you would defocus of the potential dysfunction, but improving cancer-related knowledge and supporting resources in order to regain a positive image of the body, to strengthen self-esteem, and to rebuild a safe and welcoming home again. Thanks a lot for your attention.